Good morning, everybody. Dr. Aki Al-Zubaydi here today. Had a really good task force webinar yesterday, and we went over a couple of articles and also talked about how you should ramp up your service line, especially for pulmonary nodules and lung cancer screening. We went in depth into an article that was published by Dr. Peter Mazzone and others, the management of lung nodules and lung cancer screening during COVID-19 pandemic. Just wanted to issue a quick correction. And I'll bring that article up right now. And discuss scenario 6, which we specifically talked about yesterday on that webinar, and just wanted to make a quick correction. So Dr. Scott Skibo had mentioned that scenario 6 is corresponding to a LUNGRADS 4A, and I had asserted that actually that was a LUNGRADS 3. However, actually, scenario 6 is talking about a part solid nodule with a solid component that's 6 to 8 millimeters in diameter, in which that follow-up would be due for a 3-month follow-up. So if you look at this, 4.7 is 3 months after the nodule was identified. And I had made a reference to what would correspond to scenario 4. Which is a LUNGRADS 3. So just wanted to make sure that there was no confusion about scenario 4 and scenario 3. However, if you look at what the difference is that a truly just solid nodule that is between 6 and 8 millimeters, the normal interval would be 6 months. And then you may delay that 3 to 6 months for a total of 12 months total in terms of the buffer that you have. For follow-up. And then if you do have a part solid with 6 to 8 millimeters, then that would be like that was discussed in the webinar, you have until month 9 to get that patient in. So, just again, this is a good guidance document here that gives you some buffer and gives some different scenarios about who you should see now, who you can delay, how long you can delay, and just wanted to make a quick correction on that. Outside of that, just wanted to continue to urge people to create standard operating procedures, in addition to even marketing, going out to your standard operating procedures. And I apologize, I have my wonderful daughter here, Layla. Come over here. who's used to us. Obviously, everybody's working at home, but. Just wanted to say everybody should start to ramp up their service lines if they can, and if that's appropriate per CDC and local government mandates. Here in Denver, I think we're hoping that that's going to be lifted on May 8th. Other places, the restrictions have started to be lifted, and I think it's great if you could get going with service lines, seeing patients. Hospitals' mission is patient care. And that includes non-COVID patients. So now I think that we're in a good place where PPE is there. Testing, if you look at the number of patients that are tested per million, I think we're only second to Italy now. And so we should have adequate testing. We should have adequate PPE. There should be adequate SOPs. The hospital should have enough time to have created an operating procedure that is safe. For both the staff and for patients. And then now what we want to make sure is that we get the highest risk patients in who need diagnosis now or who need patient care now. Otherwise, they're going to have increased mortality and morbidity. Get those folks in now. And then as we've been saying, then you can start to backlog these other patients. And just like we're doing with pulmonary nodules, you should do that with every service line. And that's how you're going to restart this hospital financial engine, which is also an issue because if you look at cash flow for hospitals and what's going to happen in the summer if they don't start now with ramp up, some hospitals could be in trouble, and obviously we don't want that because there's detriments that come from not having cash flow or not having a certain patient population have access to care. I know I've been to a lot of different towns and cities where I can go, a mile, 2 miles, 5 miles and get to a hospital. However, if that hospital isn't able to continue running, then, it's an hour and a half, right? And so think about like dialysis patients who, need dialysis 2-3 times a week. And If a hospital shuts down that was offering dialysis services, or it just causes just a lot of burden on people who are seeking out normal patient care. So just wanted to mention the correction and continue to beat the drum, right? SOPs, triage of patients, segment your patients, and let's get it going very, very safely. And let's make sure that we don't expose staff to COVID and don't expose any patients to COVID either. Hope you have a good day. Looking forward to Friday and looking forward to the weekend, and probably going to end up doing these briefs 2 times a week going forward. And then we'll have a cadence of every 2 weeks of webinars. So looking forward to that too, and with the task force. Talk to you guys soon.